So, in this lecture, we're going to talk about themes that have been covered in the course and try to put it all together in a sequence which hopefully will rekindle all the things that you've learned and try to put them in some context that can be applied to your future research needs. The major themes that we've considered have to do with the progress that's been made in studying the epidemiology of substance use disorders. And remember, as little as 50 years ago, less than a lifetime, relatively little was known about substance abuse. Relatively little was known about how to study it. And with the epidemic of substance abuse during the 1960s, which continues to the present day, combined with a growing rate of alcohol abuse during this period, and a global epidemic of tobacco-related diseases, substance use disorders became a very important agenda item for public health and clinical medicine. And epidemiology allowed us to make significant progress in understanding the causes of substance use disorders and how they're distributed in populations in the United States and in other countries. So what you've encountered in this course is a lot of information that has been quite new and often borrowed from other areas of epidemiology. And we've made a lot of progress in the development of research methods. These methods can now be used to accurately estimate the incidence and prevalence of substance use disorders, as well as comorbid psychiatric conditions. The methods and designs and measures can be used to understand causes as well as ways to prevent their occurrence. And certainly we've used these methods to improve early identification and treatment, as well as prevention measures. So the epidemiology of substance use disorders has grown dramatically, introduced new innovative methods to study substance use disorders, and has contributed, as we will see, to the estimation of the global burden of disease and how substance use disorders contribute to that. The traditions that we've studied on and off in this course are quite diverse. So in a sense, if you understand substance abuse epidemiology, you understand all forms of epidemiology itself, because it incorporates psychiatric epidemiology and the progress that's been made in understanding how people develop psychiatric disorders and their prevalence rates in populations using clinical structured interviews. We've also borrowed from social epidemiology, particularly in survey research that measures substance use and substance-related problems. Chronic disease epidemiology comes in when it is necessary to understand how these substances contribute to mortality and morbidity, and what the attributable risk is. For example, with liver cirrhosis and alcohol, about 90% of liver cirrhosis is attributable to the ingestion of alcohol. Clinical epidemiology has been very important in understanding what types of programs and interventions can reduce substance abuse in people who have developed a dependence syndrome. And as you've heard, genetic epidemiology is extremely important in understanding how substance use disorders might be transmitted through genetic factors from one generation to another. And finally, we've talked a little bit about pharmacoepidemiology, and you'll learn more about it in the clinical research course, where we can use methods that have been developed to evaluate how different pharmacological agents, pharmaceutical agents in particular, can reduce or prevent substance use disorders. So we started this course with a review of incidence and prevalence, but also with a review of research designs that have been incorporated into the epidemiology of substance use disorders in order to study the distribution and determinants of substance abuse. We learned about randomized clinical trials, but we also learned just about descriptive methods in epidemiology and how you can describe prevalence rates within a population accurately in order to use these data for planning and for research purposes. We covered quasi-experimental and correlational studies, as well as natural experiments when things change in terms of policy or epidemics emerge. We can compare one group of people who has been exposed to another group that hasn't in order to learn about how population rates are driven by events and risk factors that exist in the population. And we've also covered qualitative research as well as other types of research that are useful in understanding substance use disorders. One useful way of looking at the cornucopia of research designs that are available for someone who's trying to study substance use disorders is to use this particular flowchart, which compares experimental studies where randomization occurs to observational studies where randomization does not occur. And within each of these general areas, we have a variety of different research designs, which we've spoken about, that are useful. And you will encounter them as you go on in your careers in substance abuse and more generally in public health as research designs that suit particular needs. It is important to realize that there's no perfect research design for every question. You need to select an appropriate research design that's going to provide the most useful data. And sometimes experimental designs are not going to work. You need observational studies. And often you need both types of designs in order to get a triangulation of the mechanisms that might be responsible for a particular substance use disorder or substance-related problem. We also talked a lot about measurement techniques. And over the past 50 years, there have been literally hundreds of measures developed specifically to focus on substance use disorders and substance use itself, as well as measures of risk factors and consequences that are useful in putting together a battery of assessments that would suit the needs of a particular research study that is devoted to a question that you need to answer or a policymaker needs to answer. We've got hundreds of methods, research measures, ranging from biological markers that reflect recent substance use or the damage caused by substance use to body organs that can be useful for estimating risk or severity, as well as self-report measures, particularly psychiatric interviews and problem severity scales. And you can select from these measures in order to put together a battery that will help to identify key questions that are needed to be answered. Most of these measures have good to excellent accuracy. The term for that is validity, and reliability or consistency. So they're quite respectable in terms of producing good information if you apply them in a proper research design. We know that sociodemographic variables are important: age, gender, socioeconomic status, as well as race and ethnicity. And we've talked about how to measure these constructs and what they mean. And they're very important, not just as control variables, but often as explanatory factors. We've talked about measuring and interpreting psychiatric comorbidity. And we have introduced the major diagnostic systems that are used in many countries. Worldwide, it's the International Classification of Diseases, 10th revision. And in the United States, the Diagnostic and Statistical Manual of the American Psychiatric Association in its 5th revision, or DSM-5. These types of diagnostic classification systems, combined with structured and semi-structured psychiatric interviews, have enabled us to identify the psychiatric conditions that occur often with substance use disorders. And the big groupings that we've talked about are externalizing disorders and internalizing disorders. Externalizing disorders are related to an individual's behavior, often manifested in conduct disorder, antisocial personality, risk-taking, sensation-seeking, impulsivity, and other personality factors. Internalizing disorders are disorders that are quite disturbing to individuals. The major internalizing disorders that we've spoken about are anxiety and affective disorders, or depression and mania. These two disorders are interrelated with substance use problems in rather complex ways. And often externalizing disorders precede the development of substance use disorders and contribute to their severity, whereas internalizing disorders are often either independent of a substance use disorder or the consequence of heavy drinking or heavy drug use. So we've learned a lot about how comorbid psychiatric disorders are related to substance use disorders through epidemiological methods. And we know that in some cases, the associations are causal. In some cases, they're etiological, as in the example of internalizing disorders. And in some cases, both substance use and the psychiatric disorders are attributable to third factors, which are common to both. Finally, we've talked a lot about theoretical models, and guiding our understanding of substance use disorders is the theoretical model of the alcohol dependence syndrome, which has also been applied to other drugs of abuse, particularly opioids, cocaine, amphetamine, or stimulant-type substances. This model of dependence explains how people's behavior, their thoughts, their lives get captured by psychoactive dependence-producing substances. And it starts with social learning, where people get introduced to recreational substance use, whether it's alcohol or other drugs, and it's manifested at a behavioral level, at a physiological level, and at a psychological level. These types of symptoms that people experience over the course of time are incorporated into the diagnostic criteria for substance dependence in ICD and substance use disorders in DSM. And as I mentioned, they start with recreational or social learning, Ultimately, some people find that they can escape personal problems by reducing anxiety and depression and getting reinforcement, positive reinforcement, as from the reduction of stress and anxiety. And escape drinking and substance use then become a way of intensifying a person's substance use. How we move into that transition from recreational use to escape and avoidance learning is a fascinating concept, and it is partially explained by an individual's vulnerability factors, their personality and their genetics. Some people transition quite rapidly from social drinking and substance use to escape drinking, and ultimately to relief drinking to relieve withdrawal symptoms. And when they get to that final stage, they have what is called this dependence syndrome, which is very difficult to reverse. It's something that on a neurobiological level represents structural changes in brain chemistry, and it helps to explain why even though a person might be abstinent, they are quite vulnerable to relapse because of all the learning that's gone on in their social life and in their physical life over the course of time when repeatedly they've self-administered these substances. Another conceptual model that we've talked about is a framework for how vulnerability factors lead to dependence as well as harmful consequences. And that depends on personal antecedents like demographic factors, as well as personality factors and genetic vulnerability, as well as the social environment and the physical environment that people live in. And when they are living in an environment where personal antecedents and social antecedents are combined with ready exposure to different substances, that creates a strong likelihood that people will begin to use psychoactive substances for recreational purposes and ultimately in ways that are harmful to themselves and to others. The modifying variables that are often determinants of how severe a person's problem is going to develop into have to do with the doses that they're taking, the types of substance, what they've learned in terms of psychological expectancies, and their nutritional status, as well as how long they're using. For some people, they can go from exposure to consequences without developing a dependence syndrome. For many people, problems exacerbate when they have a dependence syndrome with tolerance, withdrawal, and impaired control. But as we know, that leads to acute consequences as well as long-term consequences. So, a final theory that we've considered in this course is upstream factors that contribute to the epidemiology of substance use disorders, particularly government policies, corporate interest, the promotion of alcohol and drugs through the media. That creates an epidemiologic cascade, which ultimately influences the population rates of substance use disorders.